Welcome to this explainer. I am absolutely pumped you're joining me today because we're going to tackle an essential pharmacology topic, ACE inhibitors. If you've ever looked at a list of cardiovascular meds and just felt, a bit overwhelmed, you are literally in the right place. We're going to do a highly focused, zero fluff review so this stuff doesn't just make sense for your next exam, but actually sticks with you out there in clinical practice. We'll break down the complex biology into clear, actionable concepts. All right, get comfortable and let's conquer ACE inhibitors together. Here's our game plan for today. 1. Meet the ACE inhibitors. 2. How do they work? 3. When are they used? 4. Watch out for side effects. And 5. The nurse's role. All right, let's jump straight into section 1, meet the ACE inhibitors. So, the absolute golden rule for spotting this drug class in the wild? It's all about the suffix. Generic names for these medications consistently end in PRIL. We're talking Captopril, Lisinopril, Ramipril. You definitely want to burn that ending into your memory. Whenever you're scanning a chart and spot that pril suffix, boom, your brain should instantly scream ACE inhibitor. Now, before we get too deep into the weeds, it's kind of helpful to compare ACE inhibitors to ARBs for a second. Both of these drug classes ultimately target and affect angiotensin II, like they share the exact same end goal. But, and this is the kicker, they go about achieving it in fundamentally different ways. They take entirely different physiological paths to get there. Just keep that little nugget in the back of your mind as we move forward. Moving right along to section 2, how do they work? Okay, to really get how ACE inhibitors do their thing, we first got to understand the system they're actually trying to block. Take a look at the RAS system. That stands for the renin-angiotensin-aldosterone system. Basically, it's this massive hormone system in the body that works 24/7 to regulate blood pressure and keep fluid balance in check. When we hand a patient an ACE inhibitor, this entire RAS pathway, that's the primary target we're taking aim at. Let's actually walk through how this biological domino effect plays out because it's pretty cool. Step 1, the medication comes in and inhibits the RAS system. Specifically, in step 2, it throws up a giant roadblock, totally preventing the conversion of angiotensin I into angiotensin II. Now, because we've stopped that conversion dead in its tracks, step 3 happens. We stop vasoconstriction. We are literally keeping those blood vessels from clenching up, which naturally leads us to step 4. Instead of constricting, we promote vasodilation. The vessels just open up and relax. This exact cascade, that's the secret sauce behind everything these drugs do. Which brings us to section 3. When are they used? So there are 4 main clinical situations where you'll see ACE inhibitors put to work. We use them for heart failure. We use them for hypertension, which honestly makes perfect sense when you think about that vasodilation we just talked about. They are also absolutely critical post-myocardial infarction, so right after a patient has a heart attack. And finally, they're utilized to manage diabetic nephropathy. Notice how every single one of these conditions directly benefits from the mechanism we just broke down? It brilliantly illustrates the therapeutic benefits here. Think about a post-MI patient for a second. Their heart has just survived immense trauma. It is exhausted and desperately needs a break. Well, by causing vasodilation, ACE inhibitors essentially decrease the workload on that traumatized heart. It's exactly what it needs to recover. And looking at that second point, that exact same mechanism helps protect renal function, the kidneys, in our diabetic patients. It's a real powerhouse when it comes to organ protection. All right, let's pivot to section 4, watch out for side effects. Okay, if there is literally only one side effect you ever associate with ACE inhibitors, make it this one, the persistent dry cough. I've seen patients develop this, and let me tell you, while medically speaking it's typically completely harmless, it is deeply, deeply annoying for them. Patients absolutely hate this cough. Actually, it's so bothersome that if a patient gets it, it's often a deal breaker. It usually necessitates taking them off the ACE inhibitor entirely and switching them over to an ARB or something else. But why does it even happen? Well, the cause connects right back to how the drug works. Because we're blocking that conversion of angiotensin I into angiotensin II, we inadvertently cause a spike in a substance called bradykinin. And it's that elevated bradykinin that triggers the nagging, persistent cough. It's kind of fascinating, right? How one tiny little roadblock in a chemical pathway can cause such a noticeable, everyday headache for our patients. Now, aside from the infamous cough, there are 3 other major side effects you need on your radar. First up, dizziness and hypertension. Honestly, this is totally expected since we are, actively causing vasodilation and dropping that blood pressure. Second, increased potassium. ACE inhibitors carry a very distinct risk for hyperkalemia, so that needs monitoring. And third, Angioedema. Just like with ARBs, this severe swelling can come on incredibly suddenly, and it requires immediate intervention. Let's bring it all together in Section 5, the nurse's role. Because of that hyperkalemia risk we just mentioned, a massive part of your clinical role is keeping a really close eye on the patient's potassium levels to ensure they aren't spiking. You also absolutely must check BUN and creatinine, watching like a hawk for any signs of renal failure. Alongside that, you're ensuring their urinary output stays within normal limits. And of course, you're continuously assessing their overall tolerance to the med. I mean, is their blood pressure dropping dangerously low? You got to be on top of it. And lastly, as you're standing right there at the bedside assessing your patient, your ongoing priority is checking for our two most notorious side effects. You are vigilantly, and I mean vigilantly, making sure they aren't developing that sudden, dangerous angioedema. And naturally, you're listening and asking questions to make sure they aren't developing that super annoying, persistent Pril dry cough we keep talking about. Which leaves us with a final thought to wrap up today's explainer. You know the drug ends in Pril. You know it blocks the ROS system, causes vasodilation, and gives a traumatized heart a much-needed break. But let's say your patient does develop that terrible, persistent Pril cough and absolutely hates it. What ARB are you prepping to switch them to next? Think about it. Thank you so much for joining me for this explainer. I really hope this review helps cement these concepts for you, and I can't wait to guide you through our next fascinating pharmacology topic.